Hello, everybody. Welcome to the Equip Bite-Size QI series. My name is Keith McCollum. I'm a GP in Wellbank Surgery in Katie. I've been a GP for almost 30 years, and I have a long-standing interest in quality improvement. I worked for the Safety Forum for 3 years, and I've been part of the Equip mentoring as an Equip mentor for the last 3 years. So I'd like to share with you today something around an important aspect of quality improvement, which is diagnosing the problem for quality improvement. In the last of the series, you would have explored this. This is the model for improvement. It's the foundational kind of structure that we understand quality improvement. And it's made out of a series of 3 questions. So the first question is, what are we trying to achieve? The second is, how will you know a change is an improvement? And the third question is, what change can we make that will result in improvement? And the whole essence of quality improvement is built on this foundation. And the concept that we create ideas about how we think improvement can be made, and we test those ideas. And we do that through planning, doing, studying, and acting on the results. And this is often a repetitive cycle that we put in place, okay? The key thing about diagnosing the problem is that it really is really important at the beginning when you're trying to decide what you're trying to achieve, that you really need to spend time trying to consider what the problem really is. And the key question to ask is, what's wrong with our system? What's gone wrong with what we're doing at the moment that makes us want to achieve a change in the first place? This diagram comes from the RCGP guide, and it puts four elements in the process of quality improvement. And the first step is diagnosing the problem. Before you can move on to actually planning and testing, and then if you're successful, embedding and sustaining your improvement, you need to really decide how you're going to diagnose the problem. So I think it's interesting that, diagnosis is a useful analogy, because that's something that we as doctors do all the time. And so when we think of diagnosis, we often think of the medical model. Obviously, this is the core of how we do our work. And it's the learning of how to do this repetitively that makes us good doctors. And of course, the first part of that is always taking a history. That should be followed up with a good examination, followed by appropriate investigations. And then we usually come up with some sort of diagnosis and a treatment plan. But we recognize that our diagnosis might be wrong. And so we need to keep in mind all the sort of differential diagnoses. And I think there's a direct parallel with this and quality improvement. Because effectively, what we're learning when we do good quality improvement is a similar kind of system. So the first step in any quality improvement project as part of that diagnostic process is to ask the right questions. Why has our system not worked? What has gone wrong that makes us want to change? And involved in that is an important aspect, is taking a history, asking our colleagues and our patients how they feel things could improve. The next step is examining the system. So every day, all of our work is made of lots and lots of different systems. Systems are the interactions between processes and people. And so every single day, we've got lots of systems working within our practices. And so if we want to know what's going on, we need to look at our system. The next step is to measure what something that kind of reflects on if our system is working. And from that, then we can come to the stage where we might begin to define a plan and start to implement some of our ideas to change. And so there's a series of tools that help us do that. So as part of the kind of history taking, there's the process of looking at our significant events or even our complaints processes, having discussion with colleagues, maybe even formally having interviews with patients or doing surveys. In terms of examining our system, the key tool that we use for that is called process mapping. I'm going to talk a wee bit about that later. In terms of measuring, we thoroughly recommend that people do some sort of baseline audit. You need to measure where you are to actually understand if we've actually implemented any change. And then that comes together to really defining an aim and integrating our ideas for change. And that's done by using a driver diagram, which we covered in another topic for another day. So this is a very simple process map. It kind of reflects what happens in our practice, and it's around kind of managing patients with symptoms of a urinary tract infection. So a process map is just laying out systematically all the steps in that process. And it's best done when we bring all the people that are involved in the process into the room, because when we start to do process mapping, we nearly always recognize that we only know part of the process, that nobody understands the whole process beginning to end. So if you take urinary tract infections, the first thing is that patients maybe ring with symptoms suggestive of urinary tract infection or attend the surgery. So we often then ask patients to present with an MSSU. In our practice, there's an encounter form, what we call a urine encounter form, completed, sometimes by the patient, sometimes by our staff. The MSSUs then, with encounter form, are then taken to the nurse, and she often dips a sample of urine. The results are recorded in a form, and then there's a process of agreeing what samples are sent to the lab. Later on, that form is given to the doctor. They then decide whether the patient needs some treatment or whether they're going to wait for the MSSU result. The doctor then chooses an appropriate antibiotic, script is printed, and it's given to one of our receptionists to contact the patient. So that's how our system works. Now, we recognize there's a second part of the system, and that's when the microscopy and culture comes from the lab. The doctor checks the results, decides whether an antibiotic is required or if the antibiotic needs changed, script is printed, and the script is given to receptionists to contact the patient. So this is a very simple process map. There are obviously lots of further steps may be built into those, and lots of decision-making processes built within that. For example, whenever the urine sample is dipped, there's an agreement about what samples should be sent to the lab. And in our practice, for example, all pediatric samples will be sent to the lab. So within each of these processes, there's often other processes built into those. Now, if we were to think about diagnosing a problem, here's an example from our practice where a patient with chronic kidney disease was discharged after having acute kidney injury secondary to being given the wrong antibiotic as a contributing factor. And so we decided to look at this as a significant event. Was this something that happened often? Did we need to change our systems? So we usually do significant events as a whole practice team. So we got into the room and we discussed the problem together. And out of that, we decided that we needed to decide whether this was just a one-off problem or whether this was something that happened often. So we decided to do a baseline audit looking at antibiotic prescribing in our CKD patients over the last 6 months. And I mean, part of that was also reflecting on the current guidelines about what antibiotics should be used, what antibiotics should be used with certain patients. And on the back of that, then we decided the process map, what our urine process was. What that threw up was that there actually was nowhere on the urine encounter form to record whether a patient had chronic kidney disease. And as part of that further discussion, there was a fear from our nurses that this is going to take time. It was going to take time to actually look up this information when the nurses were already busy together. So before we could even start to think about coming to a conclusion about what we wanted to do, we had to go through this diagnostic process. And it integrates all of the things I've talked about. Asking the right questions about what actually happened, using SEA as a way of investigating that, doing a baseline audit, looking at the guidelines, process mapping, and then starting to have some discussions about how we feel it would actually work with people across the practice team. And out of that, then we were able to set an aim, make a plan, and start to measure some change. So in summary, diagnosis is absolutely key to coming to designing a good quality improvement project. And if you don't get the diagnostics right, you'll often find that you'll start to do some plan and change and realize you haven't really understood the problem in the first place. So in summary, here's a few things that you need to do. You need to understand the system you're trying to change. And process mapping is the key way to do that. You need to learn through data. People will have all sorts of opinions about what's wrong and how it can be fixed, but actually using data is how we explore what the problem actually is. So measure something, and audit is still relevant every day in terms of our quality improvement work. And then the other key element is discussing the problem with those nearest the problem. So, what we want is our receptionists to fill in the form properly. What we want is our nurses to make sure that they've collated sufficient information to allow the doctor to make a good decision about what antibiotic to use in this particular problem. And so engage appropriate staff. And that's often done as part of the process mapping itself. And I mean, obviously, talk to patients. You may well want to talk to patients about what their idea is, and maybe even involve patients in coming along to the process mapping issue. So, just a quick summary. I mean, these are the 4 key elements, I think, in terms of doing any quality improvement. The first thing is recognizing that if we're going to do anything, we have to change the system. You can fix the problem once, but what we want to do is fix the problem for good. And that means we have to change the system we work in. Measurement, absolutely key within quality improvement. And that's going to be covered in some of the following of the series in terms of, what to measure and how to develop run charts. Testing a theory of change. A theory of change is a very systematic way to design how your quality improvement work is going to actually progress. And the other key element is making it easy for people to change. So if you're going to create lots of extra work for people, it's unlikely that your change will be sustained. And all of that really is about learning. We have to learn how our system works. We have to learn how to measure. We have to learn how to think through our problem. And we have to learn how to influence people. All key elements within quality improvement. And in fact, one of the key proponents of quality improvement was a tool, a production system often known as Lean. And they designed all of those processes into what's called an A3 report. And in fact, within Toyota, people are not commended for solving a problem. People are commended for how thoroughly they complete and go through the process of the A3 report. And I think it's the key element within that is that they're more interested in how we learn than what outcomes are. And within quality improvement, that's exactly what we need to do. So thank you very much for just joining us today to learn a wee bit about diagnostics. I hope that's been helpful. The next time you're going to learn how to use a Pareto chart and how to design a driver diagram. So I'll leave you with that today and hope you've found that helpful and hope you enjoy the next in the series. Okay, bye.